everyone, welcome back to my channel, and if you're new here, I am Mariana and I interview the brightest minds of physical therapy. So if you want to learn from them, start right now by subscribing to this channel and clicking on the bell so you don't miss anything. Give us a thumbs up and share this video with other colleagues. Today I interview Michael Dyck, and he is the supervisor of the clinical component of the McKenzie Diploma program, and he's going to talk about it in great detail. I hope you enjoy the show. Hi, Dr. Michael. Welcome to PT Pro Talk. How are you today?
I'm doing great, Mariana. Thank you. But it's not Dr. Michael. Thank you for that, but it's not doctor.
No, doctor in Canada is different too.
Oh, I see what you mean. Like as if I had a PhD in physiotherapy. No. So actually, I graduated in the last year of our program before it became a master's program. So I just have a bachelor's degree, no master's, no PhD. But thank you for the compliment.
I keep repeating the same mistake. I did that like a couple of times in my previous guests, that they graduated before the doctor level here in US. Right. And I called them doctor. They're like, yeah, thank you, but actually I'm not a doctor. So, yep. Okay, just Michael.
Just Michael, yeah.
Okay. And how are you feeling today?
Doing good. A little bit nervous. My first time doing one of these interviews, but I love podcasts, so I'm excited to be part of a podcast. Yeah, thank you for having me on the show.
It's gonna be great.
Yeah. How are you doing, Mariana?
I'm good. Excited to have you here. I think a lot of my listeners are going to really enjoy our topic today. So I'm excited for that.
Yeah.
So let's jump right in. So could you tell us a little bit about yourself, your career, and how did you get to where you are right now?
Yeah. Do you want the long version or the short version? I'll try to summarize. I am known to be able to talk a lot, so you've got to cut me off if I'm just going way off topic, off tangents. But I guess my story is that I graduated from McGill University in Montreal, Quebec, and that's where I am right now. I was born and raised in Montreal and went to McGill University in Montreal, and I graduated in 2009. And like I said, that was the last year of the bachelor's program, where if you graduated with a bachelor's, then you were allowed to work as a physiotherapist. The following year it became a master's program. And actually the whole program kind of changed. So I was in the last year of that bachelor's program. And to be honest, I didn't really enjoy it. I was disappointed. I thought I'd be learning, I'm not even sure what I thought I'd be learning, but as I was learning stuff, it somehow just didn't all make sense in my mind. You know what I think? I don't think I'm a stupid guy. I'm not the smartest guy, but I'm not the dumbest guy either. And I was like, I've been through a lot of school already, and now I'm doing this program, and I think I'm pretty good at knowing when things make sense and when they don't make sense. And just a lot of the stuff we were learning just seemed like the puzzle pieces didn't quite fit together the way they should. So I was a little bit disillusioned by that program. And then after graduating, worked a lot of different physiotherapy jobs. I worked for a year in inpatient care at the hospital, at one of the hospitals in Montreal. Worked for a year in pediatrics at a school with kids with disabilities. Worked in a rheumatology program. Worked in convalescence, in rehab, all kinds of things, bouncing around. But it was great. Sometimes it was just short contracts, like 3 months to replace someone who was on sick leave. Sometimes 6 months to replace someone who's on maternity leave. So, little contracts here to replace people. And I thought that was great because it gives you exposure to all these different types of physiotherapy. Oh, I did some neuro stuff too. That was neat. And then, by virtue of that, it really builds your confidence as a therapist. You start to understand sort of the spectrum of disability, if you will. And you realize when you see someone in the clinic who tells you, oh yeah, 2 years ago, I had a stroke, what that looked like at the time of their stroke, because you've seen them, day 2 post-stroke. So you know what that looks like. So you can kind of imagine how this person has evolved. And same thing if they say, oh, I had a hip replacement, or I had this kind of fracture, that kind of fracture. Kind of what it looks like from A to Z. And so to understand that continuum, I think is quite nice as a therapist.
Nice, that's a good experience.
Yeah. So I kind of did that for lots of different experiences. But the whole time, like, I'm doing these jobs, but none of them were my passion. Like they were fine, but nothing got me super excited. my passion was always MSK. By MSK, I mean musculoskeletal. Um, and that's what got me into physiotherapy. Like I wanted to help people with their shoulder pain and their knee pain and get back into sport and that kind of stuff. But ironically, I wasn't working in MSK for year after year after year. I just kept finding these other jobs. But what I was doing was I was taking MDT courses. So I took McKenzie Part A and then Part B, Part C, even Part D. I took all these courses, but I wasn't using the material because I wasn't seeing that clientele. You know, I took my Part C course and I was in the middle of working in pediatrics with kids with developmental issues, you know, so I'm not going to be giving press ups to the 4-year-old kid with global delay. But I found it so interesting. So I kept taking the courses. And then eventually, right around the time that I did my Part D course, then I got my first job in MSK. And that was very exciting. Super exciting. Finally started to use all my McKenzie tools that I'd probably forgotten a lot of them. And then since then, it's been pretty much pure MSK, just musculoskeletal. Worked in a couple different environments, like the outpatient department of a hospital, and then private clinic. And I've been private clinic for at least 5 years now, maybe 6, maybe 7. I'm not very good with time, but at least 5 years been just 100% private clinic. And then along the way, decided to get credentialed. That was in 2014. So passed that exam, and I'll tell you, when I passed that credentialing exam, that was the proudest moment of my physiotherapy career up to that point. And I remember so distinctly thinking, man, I feel happier and I feel more satisfied with myself right now than I did when I graduated from university with my PT degree. You know, that credentialing exam felt more significant and more worthwhile than my entire PT degree.
I know the feeling. So
yeah,
good.
yeah. Because it's like now I feel like I'm kind of good at a system that makes sense. You know, instead of feeling like I'm kind of lost in this PT system that doesn't really make sense. Like, no, now I'm part of something that makes sense. And then it was 2 years later that I decided to start the diploma program. I might have started a year later, but I got a pretty bad concussion. So I was out for like six months. Yeah, it was nasty. So I did not apply in the next year. Waited 2 years, applied, got in, did the diploma. That's a process, and we'll talk about that, but it took a while to finally finish that process. And when I found out that I had passed the final exam, well, that became the new proudest moment of my PT career. And like overshadowing by far the credentialing exam and by so far my whole PT degree. So yeah, I got diplomaed in 2017. Like I said, I'm not too good with time, but pretty sure it was 2017. And then 2 years later, was able to apply for faculty. And so right now I'm probationary faculty for the McKenzie Institute. And if I'm giving courses or co-teaching on courses, that's through the McKenzie Institute Canada, because I'm in Canada. And in the meantime, in those last 2 years, I've become a diploma educator, and that's on the clinical side. So there's a clinical venue in Montreal, Canada, and I'm the diploma educator at that clinical venue.
Nice.
Yeah.
So that's exciting. It was super quick since you start the course and then got credential and then start the diploma and then start teaching on the McKenzie Institute. So that's pretty cool.
I guess so. If you look at it just in years, I guess it's not too long. It kind of feels like a long time because I've been part of so many courses along the way. I've assisted on courses. I've kind of helped teach. I've been a lab assistant on so many courses. I've been to so many conferences and workshops. So I guess all that stuff makes it feel like a long time. But in actuality, I guess you're right. It's only been, I guess, since 2014 I got credentialed. And then a lot of things have happened, in a fairly short amount of time. Yeah.
That's exciting. So all in, McKenzie, all in.
Oh, yeah. Oh, 100%. 100%. But, you know, and I'm already going to start the tangent off here. Like, I do consider myself in a way, a purist, right? I don't practice anything but MDT. However, I also consider myself to be fairly open-minded. So if someone comes and says, oh, you know what I found works really well? if you do X, Y, Z kind of approach technique, I'm like, oh, that's interesting. No, I'll keep that in mind. And I'll just see, if that person says that whatever thing worked, what could be the mechanism behind that? And most of the time, if it's valid, if that person is seeing that kind of success, and we can figure out the mechanism behind it, most of the time that mechanism actually does fit into the MDT template, right? It ends up not being something that's outside of the MDT toolbox. It's actually in the toolbox. But I think people's view of the MDT toolbox is sometimes very small, very constrained. It's like, oh, it's only these exercises, it's only the exercises in the book, and it's only the ones in the manual, and anything else is some other approach. So we got to just stick with that. And well, that's just not true. That's just not true. Anyway, we can chat about that later. But yeah, I think I'm a purist, but also open-minded, or at least I hope I am.
Good. So now we are going to talk a little bit more about the diploma program from the McKenzie Diploma program.
Sure.
And so could you tell us what is the program, how does one get in, and what are the steps to the whole program?
Yeah, sure. So the McKenzie Diploma program is, it is considered the highest level of training that one can get in the McKenzie approach. If you become faculty, then that's another sort of different kind of training, and one could consider it a higher level, but that's really more pedagogical and not so much the actual, the hard skills of what is MDT. So really in terms of the hard skills and some of the soft skills of MDT, the diploma is the highest level of training. And I'll talk about the prerequisites. In order to do the diploma program, one, of course, has to do part A, B, C, D, and then the credentialing exam. If you want to do what some people call part E, or what they call now advanced extremities, if you want to do that course, then that's fine, but it's not a prerequisite for the diploma program. If someone does CSUs, that's in Canada, we call them CSUs, which means clinical skills update, or in the United States, they call it clinical decision-making course or a master class. All of those are great, and you can do conferences and all that, but those are not technically prerequisites for the diploma program. The only prerequisites are having passed the credentialing exam, and to do that, of course, you need part A through part D. Mm-hmm. And so then you apply, and the applications are usually need to be done by the end of September, I believe, or sometimes it's early September, sometimes late September, but usually early fall, the deadline, that's when the deadline is. And then the actual program starts in the winter. So usually January, February, the actual program starts for that year. And they don't take an unlimited amount of people. It's a finite number of people. That number sometimes changes year to year, but usually it's around between 20 and 25 people is usually sort of the maximum number of the cohort in a year. So you look at all the applications quite carefully, and unfortunately some people are not accepted into the program. And if you are accepted into the program, then you start in January, February, and you start with the theoretical component. And the theoretical component essentially is 1 semester of online learning. So there's an online platform that's used. I think this is becoming more and more common now, especially with the pandemic. Everyone's doing online learning. But this has been going on for a long time. Pre-COVID, this was going on for the McKenzie Institute. It's 1 semester of online learning, which is really neat because there are kind of some lectures that you listen to, but a lot of it is also conversational with other diploma candidates from around the world. They call it the International Diploma Program, and you really can't forget how international it is. There are really people from all over the world, which makes things complicated in terms of time zones. I'll tell you, you're trying to set up a meeting with someone in Mumbai, and it's like, oof, well, maybe 7 a.m. for me, and that's 11 p.m. for you, and it can be a little bit tricky. But it's neat. You get to connect with people from around the world, a lot of conversation, and you realize how much you can learn just from kind of working through issues with colleagues, and obviously doing tons of research. There's a lot of reading, a lot of articles to look at, and so a lot of self-learning through that online component. But you're being guided and cued and kind of brought along the way the whole time by various instructors. And so it's really an excellent program. Some people make the mistake of trying to continue to work full time while doing the online component. And usually by the third or fourth week, they realize they're going to break.
Work.
You only have 24 hours in the day. And if 8 of those are spent with work and then another 3 or 4 are spent with the family, then what's left to do your diploma? Not very much. So I do recommend that people take that into consideration. The Institute recommends it. I do it as well, that either you cut down your hours a little bit, or you consider even, taking some time off to really focus on that online component to get the most out of it. Just like any kind of learning, the more you put in, the more you get out of it. Sure, you can scrape by just doing the basic readings and basic participation, but it's such a unique program, and it is so specialized, and it's, in a way, it's quite elite, right? You've got to be it's just sort of like a program for the best of the best, in a way. Like that kind of program, you don't want to just shrug it off and be like, I'll scrape by. It's okay. Like, no, this is the kind of program that you want to give yourself, 100%, if not 110%, to get into it, so that you can take out as much of it as you can. Then that online component, being the semester, usually ends kind of like as a usual typical university semester might finish in April or May kind of thing. And if you've successfully completed that semester, then you're allowed to continue on with the clinical component. And most people do continue on, but unfortunately, some people don't get past that theoretical component. And so, at every level, the Institute is quite careful to make sure that people meet certain standards to move on to the next level of training. And that's one part of the Institute that I respect very much, is that it's rigorous the whole time. So if you do get through and you're able to do the clinical component, then you choose. There are different clinical venues around the world. Some countries have clinical venues only for people of that country. I think one example is Sweden. Another example is Denmark. I think a third example is Australia. There are places in the world where you can do the diploma program, but you have to be a citizen or resident of that country. Just part of the laws of the country. They don't want foreign therapists treating their citizens. But there are some sites around the world for international students. To my knowledge, there are about 4. There's one in Austin, Texas. There's one in New Jersey, USA. There is my site in Montreal, Quebec, Canada. And there's a site in Dundee, Scotland. So to my knowledge right now, there are 4 that take people internationally. I could be wrong on that, but that's what I think the current situation is. So if you're doing the international diploma program and you can't do it in your own home country, then you select one of these 4, and based on preference and dates and all that, then you get kind of dispatched to one of those sites. And that there is sometimes a waiting time between when you finish the theoretical component and when you can start the clinical. There's sometimes a waiting time. Now, when I did mine, I had to wait for about a year in order to go and do the clinical component. Yep. Just because there were people before me who had to get through the program themselves. At this point, I think we had kind of caught up, and so people were able to do the clinical part pretty soon after the theoretical. Except now with the pandemic, now we're in a bit of a backlog again because things had to be paused. So you have to. It's kind of good to know about that when you're signing up for the whole thing. Is things are not immediate. There is some patience that is necessary. So you might have to wait a little bit, and then you go to your site, and then the clinical component itself is 9 weeks, and those 9 weeks are pretty magical. I think no one would try to underplay how life-changing those 9 weeks can be. Certainly the theoretical part is great, and you learn a lot, and people feel already kind of transformed by the theoretical component, and they have no clue how transformed they will feel after the clinical component. And I'm not speaking just from Montreal folks, but this was my experience. I did my clinical component in Austin, Texas. But any diplomat you talk to, you say, hey, how was your clinical component? And you just see like the sparkle in their eye, like, oh, I did mine in, and then they start telling you the stories, and they'll start telling you how hard it was and how they had to sweat so much, and all the terrible things. But it's not that terrible. It's great. But it's like everyone builds up their own like mystical story of the clinical component. But it really is special, because for 9 weeks you are doing 100% MDT, and for most people, they're doing it at a level that they didn't even realize was possible. I think a lot of folks say, "Oh yeah, I use MDT," and they think they're quite pure about it. Usually, they're not as pure as they think they are. Usually they're sneaking in some other things. They're doing a bunch of core stabilization or other things. Not that there's anything wrong with core stabilization necessarily, but it's not. It doesn't always have to be part of the home exercise program. I'd say most of the time, it's not. But people sometimes have these habits of adding in other exercises, of explaining things in a certain way, of using certain analogies. Like, oh, that's not really part of the MDT, toolbox. And so, especially for the extremities, that's where people are usually really kind of not using MDT to its fullest capacity, to its fullest potential. It's in the extremities. So they arrive and they're usually a little bit shell shocked. And it takes a good week, if not 2 weeks, if not 3 weeks, to kind of just get used to the place, to settle in, to understand how the systems work, to realize like, oh, they were practicing MDT at this level, but now they're going to be pushed to something much, much higher. And it's always a mix of feeling nervous and scared about that, but also very excited, because if everything goes well, by the end of the 9 weeks, they're working at this new high level. Now, folks who are just listening to this can't see, but I'm showing my hands being either low or high. So Mariana can see it because we're zooming, but for those listening in, they can't tell. But yeah, so it's this equal mix of being pretty scared, but also so excited, because they think, man, like that could be me 9 weeks from now. And if things go well, then that is them 9 weeks later. And the transformation is powerful. Not to say that it's easy. It's tough. And our job as clinical educators is to be there, like very, very close. We are watching, especially in the first 3, 4, 5, 6 weeks, we're watching like a hawk. And we might not be saying very much during the clinical interactions, right? But we're observing, both in terms of what's happening, how is the patient behaving, what's their body language, what's their communication in response to the therapist's body language and communication. And of course, what is the therapist thinking? How quickly are they differentially diagnosing or classifying? How smoothly are they jumping into the assessment and doing the necessary tests? Are they doing tests that are not necessary and they're wasting time testing things that actually are not going to change the story at all? We're looking at all these things super carefully, and then we allow ourselves to, we give ourselves time in the day for feedback, and that's super important. Some days, I've had some days with diploma candidates where we might see 2 or 3 people, like, a tiny day in terms of clinical care. And yet we'll spend the whole day working hard, because the feedback on even 2 or 3 clients, that could be 2 or 3 hours, right? And one client interaction can lead into so many different topics of conversation. If the person has spinal stenosis, or you think this was a case of spinal stenosis, well, now you've entered into a conversation of what is spinal stenosis and how do we recognize it and what's the management. And if the person showed some, what we used to call yellow flags, and now we call it other drivers of pain and disability. Okay, well, how do we recognize those, and how do we address them? Like, there's so many talking points that can come out of one interaction. So there are always ways to fill the time, even if we only see a few patients, but usually the days are fairly full with patients. We give ourselves time for feedback and we go over that. So that's the clinical component. And it's quite, I guess not stringent, that's not the right word, but it is quite demanding. Candidates are expected to improve steadily in terms of their clinical reasoning, in terms of their assessment skills, in terms of their management understanding and skills, in terms of their education and communication with patients, and in terms of their hands-on procedures, their proficiency with the hands-on procedures. So in each of those 5 areas, they're expected to show steady, regular growth. And by week 9, at the last appraisal, hopefully they pass. Yeah.
Yeah, that's amazing. So I imagine how hard it must be. Just like in all the terms, people probably are so nervous being observed by other
Yeah.
PTs.
Oh,
And
sure.
but I'm sure that the feedback's great, because sometimes I think we are so used to do the things in our ways that we build our process, and not necessarily are the ones, like you said, that we think you're doing poor, McKenzie, but then you are so used to use other tools or other things that you don't even realize that you do. Most people don't get out of the college and just go straight to the McKenzie. So you learn different techniques, you have different experience. And I think it's hard to just, okay, now I'm gonna be poor on this, and like
Mm-hmm.
not use other techniques that you have previous experience, that you think are good on this specific situation, that you can like get it done, or that make the patient better with like that McKenzie specific technique. And sometimes pretty much because you don't have that knowledge in depth, and so you just use other things that you think are going to help you, that you probably not even think about other possibilities that the method gives as well, that
Yeah.
we probably don't have any idea, or don't have the experience, or never learn in much depth. So I imagine that the diploma gives that confidence
Mm.
and that ability to use this whole extent of the method, right?
Absolutely. You've touched on a couple of really interesting points that I'll kind of elaborate on. So firstly, you mentioned, it must be hard to have someone observing you. Absolutely. And that's why like those first 2-3 weeks, it's really an adjustment. I remember for me, I, I live in Canada. I went to the US. I mean, the two countries are quite similar in many ways, right? We speak English. A lot of the cultural things are the same, similar TV shows and all that. And yet it took me 3 weeks at least to feel comfortable. And part of that was because there were some subtle differences in culture, very subtle differences in the way people spoke. But also I wasn't used to folks watching me. And so, yeah, those first 3 weeks are difficult. And one of the biggest roadblocks or challenges for candidates is ego, right? Because they're used to feeling like they're pretty good at what they do. And now they're going to be criticized. And unfortunately, some people cannot allow themselves to be vulnerable in that way. You have to allow yourself to be vulnerable. You have to seek it out. You have to almost enjoy it, to know, okay, I'm going to be vulnerable here. I am opening myself up to criticism. It won't be easy. It's going to hurt at first when they tell me, you could have done this a bit differently and that could have been better. It's going to hurt a little bit. But when that little wound heals, I'm going to feel so much better. Right. So we've got to put our ego aside. And I tell the candidates day one, we're on the same team here. Right. After the session with the patient, I'm going to give you tons of feedback and I'll say, this could have been better and that could have been better. And next time, let's try to do this. But you can't view it as an attack, because if you think that now I'm attacking you, now it means we're on 2 different teams. We're not going to grow. Right. My goal is to see you succeed. And so all this criticism is out of love. It's out of love for the program and for the method and for you. And it's to see you grow. So they have to remember that we're on the same team, even when we've just had a tough patient and the emotions are high and all that stuff. I'll come in, I'll give my feedback, but we're on the same team. And most people don't struggle too much with that, but for some people that's a big struggle, just getting that criticism. So I wanted to touch on that. And then the second point that you brought up, and I think it's extremely valid, is the idea that some therapists are used to getting success using other things that are outside of MDT. And that made me think of the whole idea of, we're here to understand the patient, not to treat the patient. And that can take a while to break down as a habit. I think it's something that comes out of PT school for some of us. We want to make people better. For a lot of us, that's why we became therapists, is because we like to see people get better. I don't know any physiotherapist who likes to see people get worse, right? So most of us like to see people get better. It makes us feel good, and the person's feeling good. But the reality is we can't always do that. Sometimes we have to recognize the limitations of our own profession. And the second reality is the only way to help someone get better is to understand their condition. And so we've got to put the reins on ourselves. And even if we think, ooh, if I just give this person this exercise, they'll feel good. Like, oh, hold on. Before we just jump to that conclusion and try to make them feel good, let's really understand what's going on. And that might mean not giving that exercise that we think is going to be, if it's a derangement, let's say, then we think the exercise that we think might be reductive. We might start off by being provocative. May not make them feel better right away, but if the patient learns from that provocative exercise exactly what they need to avoid for the time being, that's huge. Now the patient has understood their condition so much better, and the likelihood of success has just doubled. So yeah, that's another part of it is trying to change that habit of immediately making people feel good and taking that neutral voice, kind of more of an objective, neutral voice of just trying to understand them. And that's one thing that we get into when we talk about communication and education is how to be sympathetic with someone, how to show that you're listening to them, you're a warm, compassionate human being, and yet still maintain that sort of professional distance and that objectivity. And sometimes people think that if they seem more social and more friendly, that the person will enjoy it better. But I find 99% of the time, people will actually respect you more and will feel better about the session if you keep that slight professional distance. You can still be friendly, but without seeming like a friend, right? There's a difference there. Well, I'm not your friend, but I'm friendly. And just maintaining that slight difference actually earns you so much more respect. Anyway, see, now I'm off on a tangent again. You've got to cut me off, Marianne. You got just say, okay, Michael, shut up. Let's move on.
So just commenting what you just said, I think there is the balance that you have to learn, like this subtle difference between the way that you communicate with the patient to be more effective. So I think that's something that you learn with the time, and probably with people watching you and they already have this experience, is much easier to get the feedback and try to learn from them. And I think if that's the point, you should be open, right? You're entering the program. Do you want to improve? You don't know everything. So you are there to learn more and be better. So I think being open is the point. Like, why you are doing that if you think that you're so good, already so good, so you're not there to learn and learn from the ones that already passed through the process and have the experience and have this high level training. So the other point that I think is very nice about you said, that we are there to understand the patient, because I think you are so anxious. We want to help them, and you kind of skip some steps. Mm-hmm. So learning to be patient and understand and observe the patient and understand what's happening, I think that's something that a lot of us PTs, we don't do, because we are so anxious to give something to make them feel better, to show like, yeah, you can get better, you can improve, and you just go straight to the exercise and start testing. And I think this anxiety that we have is something that we have to learn to breathe and be patient and go through the process. So I think probably having something very systematic that you have, like to follow the step by step that I think the McKenzie gives you, I think that's a huge part of the training probably. And that's one of the things that I would imagine that would help doing the diploma, and having someone watching you, observing you, and telling you, you are not forced, but you are there following the steps on the way that it's supposed to be. So I think that's something huge probably that helps the therapists a lot.
Oh, absolutely. And it's so unique. I mean, I don't know any other advanced training program like that, where you are, one-on-one for 9 weeks, getting that kind of close personal feedback. I don't know. Maybe there are other types of physiotherapy where there is that kind of program. I'm not aware of it, and but it's fantastic. And it's kind of like back in the day, you had shoesmiths and people who worked trades. And you had like the master and the apprentice, right? And then the apprentice would watch things and learn and get better. And it kind of feels like that in a way. You know, it's this ancient way of learning. But is there anything better? I don't think so. You know, it's one-on-one, and our job as the educators is to really sort of learn how the candidate is thinking, so we can see how they think, so that then we can, you know, try to influence that and try to make it some adjustments and sharpen their thinking and all that. Um, so yeah, I don't think you can get that something personalized like that anywhere else. I realized I never finished actually talking about the whole process. We talked about the clinical component, and I got off onto some passionate tangents. But then what happens afterwards? Because that's not the end of the process, actually. After the 9 weeks, if those 9 weeks are successful, and unfortunately not for everyone they're successful, some people don't pass their clinical component. But if you do pass the clinical component, then you're required to wait a certain period of time. Usually it's 2 months. You're required to wait 2 months, and then you're allowed to challenge the final diploma exam. And that's something that people sometimes aren't aware of when they start the diploma program. They think it's just theoretical and clinical, but no, there is this final exam, which is extremely important. If you don't pass that exam, kind of the rest doesn't mean anything. You don't get a piece of paper for having completed your theoretical or for having completed your clinical. You only get the piece of paper when you pass that final exam. And the format of the exam used to be of one type, and now because of the pandemic, I think it's changing to another type of format. It used to be a 2-day exam, and so your stress was prolonged over 2 long days. But now that might be changing because everything is changing due to the pandemic. Yeah, and sometimes that exam requires more travel. You know, people travel 9 weeks to go somewhere for the clinical. The final diploma exam, unfortunately, does not take place in every country, in every city. So like I myself had to travel to Atlanta, United States, to do my exam. And some people probably have to travel quite further than that internationally to go do that exam. So that's the final step there of the process.
Okay. And so what do you think that most diploma candidates, they hope to get out of the program?
I think that depends on the candidate. You know, some people come in and say, "Oh, I'm really good at clinical reasoning, but I'm terrible with the hands-on procedures." Okay, and then hands-on procedures might be a big part of what we're looking at. For a lot of people, I'd say it's the opposite. A lot of folks have pretty good hands-on procedures, and the clinical reasoning needs a lot of work. For most people, it's a bit of everything. They need a little bit more clinical reasoning. They need to perfect their hands-on procedures. Maybe there are some parts of the assessment that they're not too sure about. Often there are a lot of questions about management. Like, yeah, so this person seems to have an MURS. So actually, what should we do here? You know, there are some clinical areas that maybe don't get the same kind of time in courses covered that people feel really confident with them. So usually people have kind of a mixed bag of expectations. But they want to, I think what they're all looking for in common is they want to have that sense of clarity. You know, they want to feel like they're a therapist who is confident, who can go through a patient case and maintain clarity throughout that case, where they know what the next step is. And I think that's often what is seen on courses, right? You're there for a 2-day, 3-day, 4-day course. The patients come in and you see an instructor who has no idea who this person is. But the instructor is staying calm and they're asking their question, one question at a time, and nothing seems to be hurried. And patient goes home, and next day they come back and again, nothing is hurried. It's one question at a time. Somehow the instructor seems to be calm the whole time. And you're like, man, in the clinic, I'm never like that. I was like, okay, so do you think your pain's better or worse or the same? Like, you know, a lot of us initially have a tendency to try to like move along further. We're looking at the clock. Oh no, I only have 10 minutes left. What am I doing? And so even though we can understand material in theory, putting it into practice doesn't seem as fluid, doesn't seem as calm, doesn't seem as clear as what they see on courses. So for me, that was definitely a big thing. I was like, I'm credentialed. I think I'm getting pretty good at this stuff. How come when I go on courses, I still feel like I'm terrible compared to the instructor, right? So I was like, okay, so what do I do about that? Well, let's keep learning. Let's do the diploma program. And I think that's probably true for a lot of folks is even though they've done the credentialing exam, they still feel like there are a lot, and I call them like knowledge gaps, or you might call them gray areas, where just like they know how to deal with arrangements really well. They might feel very comfortable with dysfunctions, but then what about that person with the MURS, or what about that person with stenosis, or does this person seem to have a combined, like actually their shoulder pain is partly referred from the neck and also partly a derangement? Oh, so what do we do now? How do we handle these people now? What about chronic pain syndrome? A lot of question marks. So most people have these question marks and they want clarity.
Yeah.
And I, I think I can speak for the people who have come through our program. Most of them leave with that sense of clarity. I know I did. I finished my time in Austin, Texas, and I was like, man, I, I I've achieved what I wanted to achieve. You know, if you imagine a mountain, it's like you've just arrived at a little bit of a summit, and like, oh, I've worked so hard, and I'm at this summit, and I can kind of look down at the valley below and just take in the sights, and I'm kind of calm about it. You know, and I see my patients, and I can figure out what's going on, and I can educate them quite clearly, and the patient seems pleased that they feel understood, and oh, look at that, I'm doing it in the time frame required by the clinic. Like everything kind of just falls into place, and that's a really neat feeling where you feel like, oh, now it's easy to do my job. You know, it's not a struggle to do my job. Now my job is kind of, well, it's not easy, but it's fluid. You know, and you finish your day and like, huh, that was fun. That was a fun day. A lot of puzzles to figure out, and we figured them out. You know, and
That's
I think
awesome.
most people do finish the program with that kind of sense of clarity. What you only realize later on is you're never at the you're never at the final summit of the mountain. There are always more peaks to climb, right? But at least that diploma program, it's the first main peak, and you take some time to breathe and enjoy the sights. But then as you continue to practice, you're like, oh, you know what? I could still keep learning a bit more, and then a bit more, and some more, and you keep climbing the mountain. And we never get to the summit, right? It's a lifelong journey, but it makes the rest of the journey so much more enjoyable. That's what a lot of candidates have commented to me is they realize that they haven't finished the learning process, but they're happy because now they know how to learn. They know how to challenge themselves for the rest of their lives. And often before doing the diploma, we don't even know how to exactly challenge ourselves. Like if if you can't even step back and look at your puzzle, you don't know what puzzle pieces are missing. Right? And having done the diploma, now you're able to step back and be like, oh, okay, I'm missing a piece here and a piece there and a piece there. But before that, you're too close to the puzzle. You couldn't even tell which pieces were missing. Yeah.
Yeah, that's awesome. That's a good analogy. And I just have one question for your previous comment
Yeah.
about the final test. So if you have to wait, that's always like this. You have to wait 2 months after you finish your clinical training to do the test.
Well, that information may be outdated. That was the case up until fairly recently.
Mm-hmm.
However, with the pandemic, things have changed.
Things may change. Okay.
So it may not be the case now.
And can you repeat the test if you fail?
You can. I think you're allowed to repeat it twice. So if you fail the first time, you can challenge it a second time. If you fail it the second time, you can challenge it again a third time. And I think that's the last attempt.
Okay. Yeah. Okay. And we already talked a little bit about these challenges, but my next question would be, what are the common challenges faced on the program? So I know you have some things to talk about. We already touched some of the subjects. So
yeah,
if you want to just
sure.
kind of go through them.
Yeah. They're kind of like 5 main things. And these are actually, these are things I've mentioned before, but I'll touch on them again. I think the first thing is clinical reasoning. And people love talking about clinical reasoning. It's a big part of the courses, but there's always there are always ways to get better at that. And so a big part of the diploma program is to heighten that clinical reasoning and to make people realize that to do our job as best we can, we do want to be as efficient as possible. So we could ask someone 100 different questions during the history taking, right? I could ask you, Mariana, what's your eye color? And do you prefer morning or evening? Like all kinds of like silly questions I could ask you, but I'm not going to because it's not relevant to if you, let's say I'm seeing you for neck pain, your favorite color is not part of your neck pain, right? And so along those same lines, it's so easy to ask too many questions. And I think, people go through the courses part A through D, and as they do that, they become more and more proficient with the form. So they learn the form and they get excited by the form. And then when they get good at the form, they want to use what they're good at. But now in the diploma program, it's like, okay, you're really good at the form, but now we almost have to sort of let go of the form a little bit, or only use it for the things that we need. It's okay to not ask every question. If you've asked every question, you've asked too much, guaranteed, right? There's got to be some blank. There's got to be some empty space on that form. And how do we ensure that? Well, we ensure that by asking every question for a specific reason. If I'll ask you your age, why? Because age on its own is going to tell me, is this more likely, or is this classification more likely, or is that classification more likely, right? And then I'll ask you where the pain is. And right away from that question, pain location, we should be able to eliminate a lot of different classifications. So with each question, we're eliminating more and more classifications, very much like a funnel, right? We're starting with all these options, and then with every question, we're funneling down. Once again, people listening to this can't tell, but I'm creating a funnel image with my hands. And by the end of the history, there should really only be 2, at most 3 potential classifications. And it's surprising how often people aren't used to that kind of process. Their first week doing the diploma, we might finish the history, and then we'll excuse ourselves from the patient. We go out into the hall and say, okay, so based off of that, what do you think are the potential classifications? And I'll say, oh, well, maybe dysfunction, maybe derangement, postural, but unlikely, maybe MURS. I'm like, whoa, hold on. There's no way it could be all these things, right? Guaranteed there are things in history that have already excluded some of these. And so it becomes really important to keep track of those questions, to make every question intentional. We're not just filling out the form, there's got to be intent behind it. And so when we get smart with that and good with that, we can save so much time. Like you can finish a history in 5 minutes sometimes, usually 10 at most. There are some people who you can tell, this person needs to talk. It's going to be part of their physiotherapy. Will just be kind of letting out all this kind of emotional stuff. Great. Then sometimes I'll chat with someone for 25 minutes and I know that it's not really part of the history, but it's part of the therapy. We've already started doing therapy just from chatting, but those are more exceptional cases. Usually within 10 minutes, max 15, you finished your history. And that's, for a lot of folks, they are not used to that kind of time frame. They come in and their history is 25, 30 minutes. So it's just too many questions being asked. And of course, part of that also is how clear is your question? It's so easy to ask an ambiguous question. So learning how to make things very clear, unambiguous, will save you so much time, will help for your clinical reasoning. And then of course, the physical exam, how does that help you for that clinical reasoning as well? And that brings me into the next thing that people learn is assessment. Like how do you actually do the physical assessment? And it's funny because in MDT, we're actually not assessing that much, right? When you think about other approaches where they're looking at, muscle co-contractions and stability of certain musculature and all these special tests and XYZ. In MDT, we're really looking at range of motion. We're doing some observation. We might do a neuro exam. We might do some strength testing. And then we do the repeated movement testing, right? That's it. And sometimes we don't need to do the neuro. And sometimes there's no reason to do strength. So sometimes all we're doing is range of motion. Often we'll try to get some functional baselines and then repeated movements. compared to other approaches, this is a small physical exam, but it's surprising how even though it's kind of small and limited, well, we have to do it right. We've got to do it absolutely right, correctly, precisely, so that the information is valid. And it's surprising how a lot of folks actually struggle to do it with that kind of precision. So they say, yeah, I did my range of motion testing, but it was a little bit, if it's a little bit sloppy, well, we all know, hey, did that person have pain during movement or end range pain? Yeah, okay, you don't know. Well, if you don't know, then now there are options on the table that shouldn't be on the table. If it's pain during movement, now we know it can't be dysfunction. But if you're not sure, now the dysfunction's still on the table, maybe. That's just one example, right? So there's so many things where that kind of precision is important. And I think just for fun, this would be for people, hey, Mariana, how much time do we have here? Because as you can tell, I'm talking a lot.
We still have a couple more questions.
Couple more questions. Okay. But I think people will appreciate this. We'll do a little mock example. Are you ready to be a therapist?
Okay.
Okay. And this will be especially cool for people who are watching, but I think people who are listening will appreciate it nonetheless. So you're the therapist, I'm the patient. I'm here for neck pain, right? And you've asked me all the questions, and it doesn't really matter what the questions are. We're getting what the answers to the questions are. We're getting now to the physical exam. Okay. So I've got my neck pain. Now you're going to do a neck range of motion, right? That part of the physical exam. So go ahead. How would you instruct me now to do that?
I would just first ask, can you move forward, trying to touch your chin on your chest?
Okay. So you're starting with flexion. Why are you doing that?
I don't know. That's always how I always do it. I don't know. Flexion, then I go to extension, rotation, and side bending. Maybe that's something I created on my mind.
Yeah. So a lot of folks, like you're describing that you have a pattern, right?
Yeah.
And that's good. I think it's nice to have patterns, because if we often do things in a similar way, it helps us to see patterns in our patients. But it was a bit of a trick question. I said, okay, I've got neck pain. Go ahead and start, because I didn't tell you where the neck pain was. And I would argue that before you start your range of motion, you've got to know where the pain is. Why? Because when we get to the movements that can happen bilaterally, so the lateral flexion and the rotation, you want to have in your mind an idea of like an expectation. So if in my history, if I've described what should be a derangement, and you might be expecting loss of range of motion, now you want to you have that hypothesis, and you want to see if it's the case or not. So you got to know where the pain is. So let's say I have right-sided neck pain. I would argue before going into flexion, and some of this is personal, but I find it works quite well. I usually tell folks, why not start with rotation? Because everybody knows rotation, right? And nobody is afraid of rotation. And usually we don't see rotation as being potentially aggravating. Whereas a lot of folks with derangement will say, flexion hurts. And now if the first thing you get them to do is the thing that is painful, now they're like, man, why are you making me do this? Whereas if you start with something that seems more neutral in their mind, then they're like, oh, okay, we're just looking at movements, great. Now, even for rotation, how are you going to start? I've told you I've had right side pain. So now how do you get me to rotate my head?
I would say probably try to look at the left first.
Yeah, I think that's excellent, because then you know what you're comparing against. So I would recommend that, you find out what the pain is, start with rotation, because it's something that everybody knows. Start to the unaffected side, so you know exactly what that full movement looks like, and then you can compare against that. And it's not just for you, it's for them too. Then they realize, oh, hey, I'm not going quite as far, right?
And usually it's harder on the side that you have pain, so I would start on the left just to make it a little easier, so they're not as resistant.
Right. And then they start to realize, it's limited. And now you're starting to cooperate. They're starting to cooperate with you. And then I recommend going to lateral flexion again, because it's this side to side movement that no one, thinks could be detrimental in any way. And then from there, this is just my recommendation, go to sagittal plane. And usually I wait for extension, and I'll get to that why. And I would start with flexion. People know that one. At this point, even if it's what makes them hurt, they know that this is just your process. You're looking at all these movements. Okay, so they do that. And then I'll often do protrusion after that. And it's easy to, after protrusion, then to do retraction because we've just stuck out and now we pull in. So I think folks can understand like, oh, okay, there's this one and then kind of its cousin is this other one. Because if you just pull retraction out of nowhere, okay, pull your chin in. Like, oh, what? Oh, I don't know. Nobody knows what that movement is, right? But if it follows protrusion, it's a little easier. And then you can end with extension, which most often is one of the toughest ones, right? And quite limited. And you might have to finagle a little bit and get their hands on here to see if it makes it easier and that kind of thing. And if you're starting with retraction or extension, well, then it's still fresh on their minds. You know, that movement that you just did, it was clearly difficult, right? Yeah. Okay. Let's see what happens if we repeat that one. Maybe we'll go for 5 times or 10 times. Let's see what happens if we repeat it. So it's fresh on their minds, and now they're repeating that movement. So anyway, that's just one example of something like cervical assessment, which is not difficult, but they're just little ways to make it efficient. And that just from practice and seeing where patients kind of get caught up and things that they say, just that kind of practice has kind of led me to realize, okay, here's a way that tends to work for 9 out of 10 people and is quite fluid and efficient. And with that also comes hand movement. And this is something that we talk about in the diploma program, is we are not just communicating verbally, but we're also communicating with our body. And if my now people who are listening to this can't tell, but I'm crossing my arms and say, okay, Mariana, turn your head to your left as far as you can. I mean, that's one way of communicating, and you might follow that command very well and turn your head to the left. But if I say, okay, Mariana, now turn your head to the left, and I show some kind of, either a finger or a hand, and simultaneously I'm doing it myself, I've demonstrated the movement. Right away, they'll know exactly what to do. And that comes into play because later on, you're showing them other things, retraction, extension, and they don't have to spend a few extra seconds processing it, or they have less of a chance of doing the wrong movement and then giving you other information. And you've made it clear that you're the director here. You're telling them what to do, when to do it, and that you're not only telling them when to go, but you're telling them when to stop. Because some people, you say, okay, turn your head to the left as far as you can, and they turn, and then they keep turning, right? We've all seen that. And they're like turning it 4 or 5 times, like, I don't know, it kind of hurts. Yeah, maybe, I don't. You're like, okay, stop, right? So, and now we've just lost some time. And that therapeutic alliance could have been stronger because we weren't actually very clear in our instructions. Whereas just that little use of the hands and to demonstrate, okay, turn as far as you can and come back, right? I've shown them what to do and I've brought them back. And so I've also implicitly told them when to stop. The patient now feels very at ease, right? I'm directing, but they like being directed. They want to be directed because they don't know what to do. They're here, they're seeing you because they don't know what to do, right? So we need to be that director. We need to step into that role and be that director. It's all very soft, right? It's not like, okay, turn to your head and then stop. No, it's all very soft. But by doing that, the patient can be at ease. They know they're in good hands. They know they can trust you. So all that kind of thing is part of these assessment techniques, not just being precise, but being effective. And that body language comes into that as well. What else do we talk about on the diploma program? We talk about the other category, and cut me off whenever you need to. But the other category is one aspect that I think usually there's just not much time to talk about it on the courses. Right? On the courses, we're talking about the 3 syndromes that are unique to MDT: postural syndrome, dysfunction syndrome, and derangement syndrome. And that tends to be the bulk of what is talked about. But then the other is so important: the MURS, the peripheral nerve entrapment, the soft tissue disease process, right? The recovering trauma. We actually see a lot of these. And when you think about it, that other category, all those subclassifications, that is the language of physiotherapy. That's what all the other physiotherapists around the world, that's the language that they speak. So we've got to be pretty good at speaking that language too. If we only speak MDT and we're talking to other therapists or doctors or surgeons, we're like, oh yeah, this person's got a derangement responding to lateral rotation. What? Well, what are you talking about? And then we can't create links, we can't create bonds with those other professionals. So we have to be able to understand what is the other, what's the criteria for the other, what are you expecting to see in the assessment, how do you manage the other, And then we're speaking the language of PT. And that's very, very powerful because so often we come up against roadblocks. We say, oh, this person has a rapidly responding condition and needs extension in line with hips off center or whatever. And then doctor comes back and says, yeah, but the imaging clearly shows degenerative changes of this type, this type. Well, we have to be able now to speak that PT language or that medical language and say, yes, true, the imaging findings are such. However, the history and the physical exam confirmed to me that it is not OA, or it's not stenosis, or it's not whatever the other diagnosis is because of, and then you've got to be able to back yourself up. It's not that because X, Y, Z, clack, clack, clack. Now you have to come in and have a bulletproof case as to why it's not that other, and therefore why it is this rapidly reversible condition that you think it is. So we spend a lot of time on the diploma program talking about the other, and people usually are surprised how little they understand. They understand the other. They think they know what these conditions are, and then turns out they're not that comfortable with them. But they really appreciate getting that knowledge, because now they feel, and we're talking about that clarity. Like, you can't feel clear if you're only clear on the stuff that's pure MDT. You've got to be clear on the rest of the field too, so that you know when it's not the stenosis, when it's not the peripheral nerve entrapment, or when it could be. So that's a big one. Of course, procedures is another one that we work on. And I don't think I have to talk a ton about that. We learn procedures on courses. Do we learn other procedures during the diploma program? Yes. One unique procedure that is never taught on courses are the manipulations. So we do teach manipulations on the program, and some people love learning those. What comes along with the manipulation is the education as to when to use them. And usually, what to some people's disappointment, the reality is we don't actually need them that often. Even if you know how to manipulate, if you're doing a pretty decent MDT job, you probably aren't using it very often at all. So that's part of what we teach. And then lastly, it's the big piece about communication and education. And that, we could do a whole podcast just on that, because the communication education part is so big. And I also make a distinction between education and explanation. And this is one thing I wanted to discuss with you. I think listeners might appreciate this, is definitely we know the importance of educating our patients. But I think what people don't realize, or they don't give enough value or weight to, how do we explain to patients what is happening even during the session? Because in my mind, education can come in at a couple different points. As we're finishing the history, we might give them a little bit of education to say, based on what we saw today, there is a chance that this is a rapidly reversible condition, meaning that if we find one specific movement, we might be able to create some significant change, et cetera. There are different ways of talking about derangements, but often if the arrangement is still a possibility, and usually it is, then I'll explain that to kind of say why we're about to do repeated movements. So there's a little bit of education there, but the bulk of the education is going to be at the end, right? When you've finished doing a lot of testing and you can discuss the results of all that testing. But however, along the way, we can definitely explain certain things. We can talk about traffic light guide already as we're testing. We can talk about peripheralization, centralization, maybe actually, you know what? No, that's usually at the end. But we can talk about certain principles and explain already what we're thinking and what we might see. And I consider that explanation. And I think it's so important because a lot of the candidates tend to stay very silent. They're doing their assessment, they're running the person through the history and the physical exam, but they're not really saying at all what they're thinking until the very, very end. And I tell them, make them an expert. Get this person on board as quickly as possible. So all the things that they should know it too. And if they say, oh, yeah, I'm doing this press up and it's hurting a lot. Do you just stay silent? No, we have to jump in. We have to say something, right? And what we might say is, okay, well, is it tolerable? Yeah. All right. Well, if it's tolerable, let's keep going and let me know if it gets worse or if it gets better as you continue, or if it stays the same, right? Even that in a way is a bit of an explanation, because we're saying that these are the options, and it's implicit that if it's tolerable pain, then it's okay to continue. But we have to respond to something. We can't just stay quiet. So there are various things that are good to explain along the way, gets the person on board, and then ideally by the end of day one, they've understood the process. They know that we're doing this trial and error. We're testing out different movements. They know what centralization, peripheralization is, and maybe even directional preference. And then you're a team, right? And then they're much more likely to come back day two because they've understood the process. Instead of, if you don't tell them anything, you say, okay, here's your exercise, do it 10 times, 5 times a day. Well, are they likely to come back? Much less, because what if they don't get better, right? What if that exercise turned out to do nothing, or it was provocative? Then you think, okay, this person just had this one thing, didn't work. I'm going to go see that other therapist down the street. So there's so many times to educate and to explain, and there's a difference between those two, but it's so important to do that. So yeah, that's what we look at. I'm just checking my list here. Like, yeah, the clinical reasoning, talking about the other, that proficiency during the assessment, the hands-on procedures, and then the communication and education.
I think it's so nice that you can go in depth so much more in each of these topics during the diploma, because it's really true. Like, we don't talk much about the other category, and I think it's something that I'm personally always is the part that I'm not as secure as the other parts, because it's easier to have the domain of the 3 classifications, and then on the other you kind of like, oh, and what do I do now? So exactly. I think that's super nice. And also the hands-on, I think a lot of people have questions about the hands-on because we don't see that in any car. So that's a question that I heard people asking about the diploma, if they teach hands-on technique. So I think that's nice.
Big time. And we see variations on the typical loading strategies, right? Because on courses and in the textbooks and the course manuals, they can't print, a 500-page document. It's going to be these shorter documents, and so they show the loading strategies that are most commonly useful and therefore the best to know. But are we limited to those loading strategies? No, absolutely not. There's so many ways that you can vary it. And so I recently did a webinar. This was one of the first 3 webinars offered by the McKenzie Institute International, called "The Devil's in the Details." Loading strategies for the spine, or variations on typical loading strategies for the spine. And most of it is a video where myself and David Ham, who's another diplomat in Canada, we just showed one variation after another, after another, after another. And I think people really appreciated that, because it made them realize the toolbox is a lot bigger than you think it is. And the only thing limiting your toolbox is your imagination. So go ahead and get creative and make sure that you understand what's in front of you. Is this person going to end range? That's one thing that the diploma candidates always tell me. They say, I didn't realize that I wasn't getting patients to end range. Time and time again. And so just pushing harder, further, taking out balls and belts and towels and chairs, and using all these various things to make sure they're getting to end range. And that makes all the difference, right? As the saying says, end range is where the magic happens. So yeah, that's a big part of it too.
I watched the webinar. It was super nice. Just gave me so many different ideas, even like to seeing patients through telehealth. Now you have to be creative. So it was awesome. Yeah, that was super helpful.
Cool.
I think we talked about this too, but let's see if you have something else to add. So why does the program is worthwhile and potentially life-changing?
Yeah. Well, it's definitely worthwhile because you get this unique learning experience. Now, I'm not going to hide it. It's not cheap, right? You do have to be ready to invest money. You've got to be ready to invest time. So it's not cheap in either money or time, but the reward is huge. The reward is huge. I would say it's unparalleled. And it gives you that clarity that I think otherwise, if you don't go through that kind of rigorous training, and if you don't have that one-on-one experience for an extended period of time, like 9 weeks, I don't think it's possible to get that same kind of clinical clarity. You may get it, but it might be near the end of your career. And this kind of fast forwards that whole process. It expedites things. So instead of feeling like you're pretty good at what you're doing when you're 55, well, you can feel like you're like that when you're 35. Man, if you just save 20 years, and those 20 years are going to get much better patient outcomes, well, that's fantastic, So yeah, I'd say that's why it's life changing. It just gives you a clarity and a confidence and a calmness that otherwise I think is very hard to achieve.
Mm-hmm.
Yeah.
Yeah, for
People often
sure.
comment like, "Oh, how come you're so calm?" You know, when I'm seeing patients, it's like, well, because there's no reason to not be calm, right? Like,
You know what to do, you know what steps to follow, so you have the
yeah,
process all line up on your mind, so you don't have to be anxious about it,
yeah, yeah. And
right?
then when the candidates see themselves over the 9 weeks, they see themselves calming down. Oh, they get very excited. Like, hey, this is cool. I'm able to do my job without sweating and like moving around the whole time. I get to do it and feel just happy and calm. That's a fantastic experience.
Nice.
Yeah.
And if anyone is interested in the diploma program, what are the steps that they should take now?
Sure. Well, step one, of course, is take your Part A through Part D courses. If you haven't finished those already, I don't know what the situation is in other countries. In Canada, most courses are still on pause because of the pandemic, but I think pretty soon they'll be starting up again. And I think I heard that in other countries, maybe France, some courses have already started up again. So hopefully people can start jumping onto courses again, and then credentialed. Go past that credentialing exam. It's not an easy exam, but it's an excellent exam. And then apply for the program. You definitely want to think about it. You want to make sure that it makes sense for you in terms of the commitment of time and money. But if it makes sense, then I strongly, strongly recommend people apply for the program. And then they can have the fun. There's like the fun part of figuring out, okay, where do I want to go? If I can be 9 weeks somewhere in the world, is it Canada? Is it the US? Is it Scotland? And they can figure out where they want to go. But those are the steps. Along the way, if there are master classes that you want to attend, if there are other workshops, conferences, all that can be so useful. Trying to stay on top of some of the literature is always very useful as well. There are different sites, both on the branch level and on the international level. You can go and see recommended readings, pages and pages of various articles that are pertinent to MDT things. There's the MDT World Press. There are lots of outlets that people can do. There's also a very nice tool. This is offered in Canada. I think it's offered around the world. It's called Case Manager. So there's a Case Manager series, and I think there are 3 case managers now, kind of like level 1, level 2, level 3, or part 1, part 2, part 3, and those are excellent. That's such good training for the clinical reasoning aspect. So it's online, it's questions. So obviously it's not hands-on. It doesn't deal with education, all that stuff. It really just deals purely with clinical reasoning, as well as some management components. And that's an excellent resource. And then there are all kinds of webinars that people can watch online. I mentioned one that I did, but there are tons of others. And there's the podcast to listen to, such as your excellent podcast. And then there's Jason Ward's podcast, Mechanical Care Forum. And he also offers case conversations. That's a really good resource. So just tapping into all these resources, trying to get your brain sort of speaking the language of MDT and pushing yourself to be pure, to use the system at its fullest, and not just for the spine, but for the extremities. And that's something that when people apply for the program and I find out that they're coming to Montreal, a few months beforehand, I send them an email and say, hey, before you get here, make sure that you are practicing this as purely as you can, especially for the extremities, because some folks haven't really applied it fully in the extremities yet. So all those are my recommendations for what to do before starting the diploma program.
I did the case managers, very nice, and it forces you to have that clinical reasoning, like when you see like the pain location and then you put like the possible diagnosis and they have the options. So it already like forces you to think that way. It gives some guidance on like how to do the clinical reasoning. So I think that's very nice.
Yeah, that's perfect training for the diploma. Perfect.
And so now the final questions.
Uh-oh.
Again, I think you kind of said some of the answers. So what is your favorite source of information? There is anything specific that you like to read?
I mean, I think my number one source of information is actually just directly from individuals. I love going on courses and assisting on courses and hearing different instructors speak, and they share anecdotes, right, of certain patients. And I think the way my brain works, like I love hearing those anecdotes, and they get stored somewhere in there, and then I might use that later with a patient. So actually, that's almost my preferred resource, is just hearing other experienced clinicians share their experience. I've got to say, and I know at this point they're a little bit outdated, but I loved reading and then rereading the original Rob McKenzie textbooks. Now, when I say original, I don't mean like the blue books from the 80s, but the more recent versions, published in 2003, and then later 2008, I think. So the more recent ones, I read them the first time, maybe understood 50, 60% of it, and then reread them during my diploma but during my diploma placement, clinical placement, and then just understood so much more. And since then, I haven't reread them kind of front to back, but have kind of picked up certain chapters to look at certain things, and the level of understanding is even greater, and it becomes more and more enjoyable every time I read it again. It's even clearer now because I've gained clarity. So it's like, oh yeah, sure, I know exactly what he means. So I do recommend those, even though there have been divergences, right? Since 2003, I think that's when the lumbar spine was published. Since then, we have changed some of the terminology. We don't use certain terms anymore. We use new terms. Certain concepts have evolved. So the course manuals are the most up-to-date information. But the textbooks just flesh things out a bit more, and you kind of get it's this window into Rob McKenzie's mind. You understand how he saw things. And I really enjoyed reading that, because now, like, even if I'm looking at the course manuals and I see the differences, I can easily translate in my mind, oh, okay, so, Robin called it this, now we're calling it this new thing. But I can see how that has been translated in the evolution. But I still definitely help me to get some clarity to read those textbooks. So that's a source of information. And I'll say, like, I do listen to Jason Ward's podcast, and there's some really cool guests on there. So that's a good source of information. And those are my main ones. I'll be honest, I'm not one to spend tons of time reading all the new literature coming out. Probably something I should get better at. So I won't try to pretend like I'm reading an article every day. It's more those other kinds of sources of information that kind of resonate with my mind.
Nice.
Yeah.
And what advice would you give to the clinicians that are starting their careers?
Ooh, starting their careers, like fresh out of PT school?
Yes.
Try to forget everything you've learned. So are these clinicians people who are getting into MDT, McKenzie, or just general?
Just general.
Yeah. Wow. I'll have to take a few seconds here, Mariana. That's a great question. I think the advice is going to be this. Number one, to be critical. And when I say critical, it doesn't mean just to be negative, criticizing people negatively, but critical in the sense of, if you read something or you hear something, to really ask yourself, does that make sense? Does this puzzle piece fit into the puzzle the way it should? Or does something not seem right here? And the reason I say that is because, like I said, I was very disillusioned by my university training. and only later realized a lot of what we learned was kind of nonsense. You realize that there are entire conditions that you learn about these conditions, but there's very little evidence behind them. So is this even valid? Um, one person calls it this condition, but somebody else calls it by a different name. So that's advice number one, is be critical. And number two is be critical on yourself. The most important thing for one's professional development is a self-reflection, is to be able to look back on oneself and say, okay, I just had this patient interaction, and this is what I did, and this is what the patient said, etc. And then you ask yourself the questions. Well, did I assess things as well as I could have? Did I ask the best questions, or did I forget some questions? How was my communication, my education with this person? Are there other things that I forgot that I should have included? How could I have improved? If did I go overtime? Should I have? What could I have done to shorten the time? And that kind of self-reflection, and kind of being your own critic and kind of being hard on yourself, that is the number one key for growth as a professional. And there's even a nice paper about that was talking about that, and like the difference between therapists who, after 20 years of experience, their outcomes are kind of mediocre, and then other therapists who, after the same number of years of experience, their outcomes are outstanding. Well, what's the difference between these two therapists? Is that the ones who are outstanding, they have continually been questioning themselves. Like, am I doing this as well as I can? How could I get better? Always that self-reflection. And then those who aren't asking themselves those questions, well, 20 years later, their outcomes are still pretty mediocre.
Yeah. One of the things that I was impressed when I moved to US and then finally got my license, every single clinic that I worked, they do modalities. And I had to do it because of units, insurance. And for me, it didn't make any sense. I was like, why I'm doing this? Like, why is this still this way today? So I was like, that doesn't feel right. Like, I have to do something about it. Like, I can't just do something that I don't believe. Like, why? So yeah, I think that's a big part of, you see, because it's hard when you first graduate because you don't have this view or this experience, but then after a while, you're like, I've been practicing on like private settings for like 6-7 years, and then I moved, and then I go back to doing, like, I did like few times on my life modalities, and then here I have to do like almost like every single patient. I was like, what's going on?
Yeah.
So that's tough, but let's move on.
Yeah. And people have to recognize that there will always be trends, right? And different modalities will be popular for 1 year, 2 years, and then after that, it's a new modality that becomes popular for a year, 2 years. And there's so many that pop up, and then after a few years, no one's talking about it anymore. And once again, that's because people are trying to treat and not necessarily understand. So whatever seems to provide a nice, quick effect, people jump to it. But usually, it's like it'll never get you more than maybe 10-15% of the population will respond well to it, and that's it. And that can't be satisfying. One example of trends, we're talking about modalities. When I was going through McGill, the director of our program was the one teaching us the modalities course, right? That modalities course was being taught by the director of the program. And so we all thought it was so important. Well, now I graduated 11 years ago. Now the director has left. It's a new person. And now McGill says, no, modalities are not important. They barely teach them. It's a complete turnaround. So that's even within 11 years, there can be such a big turnaround just because of, well, who's running the show. So things come and go in trends, and that's important to not just get caught up in the trend, but to really kind of examine it slowly with a critical view and see if it makes sense for you.
Yeah, 100%. So last question, what personal qualities or abilities that you think are important to become a successful PT?
Yeah. Well, I think that kind of ties into what I just said, the capacity for self-reflection and the capacity for self-critique. And I say that because we've had some diploma candidates who really struggle to be hard on themselves, to admit that they did something wrong. I forgot to check shoulder internal rotation. And it happens. We all forget to do things sometimes, right? Or I forgot to get a functional baseline. Okay, but you have to be able to admit it, and you have to be able to admit what you don't know. And so it's happened a bunch where I'm asking questions to candidates, and sometimes they just kind of make up answers, and I can tell they're making it up. It's like, it's okay to not know. We have to be able to say, I don't know. And only when you can say, I don't know, then you're ready to move on and learn it, And from what I've heard, Rob McKenzie was excellent at that. People would ask him questions sometimes. I don't know. He would just say, I don't know. And for him, did that mean that he was less of an expert? No. The true experts have no issue saying, I don't know. They recognize what they don't know, and then it keeps them learning. So that's an important quality, is to be able to self-criticize and to admit to yourself what you don't know. And then you know what to improve upon. If you try to fool yourself that you know everything, well, you're not gonna push yourself to learn anything, right? So yeah. I think it's probably that. There are a few qualities that are kind of inherent. Like when we talk about empathy, some people just naturally can be very empathetic. They connect with the patient right away. It's in their eyes, it's in their body language, and that makes them a strong therapist right away. And some people then struggle with that. Sometimes they have to kind of learn the body language of empathy and ways to speak that are going to be softer but clear, without being too harsh, without being too aggressive, etc. So those are some qualities too. Do you have to have that innately? No, but certainly if you're already empathetic, if you already have that compassion, it's going to be a much easier road for you.
Good. And if people want to know more about you or your work, where can they find the information?
Oh, about me personally?
Yeah. Or like your work, what do you do? Or if they want to contact you, if you have any questions or... Yeah,
I don't really have a website. I don't stay too active on the social medias. I try to avoid that stuff. I do run, I kind of administer a Facebook page for McKenzie therapists, but that's really just for the province of Quebec, because those conversations are sometimes in French, sometimes in English, because a lot of therapists in this province are French speaking. It's not really open to an international audience. So it's kind of hard to find out anything about me. I try to stay secretive and private. But if people want to contact me, they can certainly send me an email. I love responding to emails. So the best email address it starts with my last name. My last name is Dyck. So DYCK .Michael, MICHAEL @gmail.com. And that's the best way to contact me. I love to answer questions.
Okay, good. So I'm going to put that on the show notes. If anyone wants to contact you, they can just find the information there.
Yeah, exactly.
Okay, Michael, that's been great. A lot of information. I think if anyone was interested in the diploma program, now they have the whole big picture in a lot of details. So I think you did a great job.
Thanks. I don't know if there's anyone still listening at this point. We probably have like
they can pause and watch in 2 parts. That's not a problem. Yeah. So I think we provide our listeners with a lot of details. So I think that's great. And I hope that people are interested and find out for more information and always be trying to be learning and grow their knowledge. And I think that's take the career for the next level. So I'm very glad and happy that you accept my invitation. Thank you so much.
Oh, it was a pleasure. Thank you for having me. It was really nice talking with you. And thanks for this opportunity.